So thank you again to be with this wonderful faculty, and I will try to give you one experience that maybe come out with some comments from all of you. There was a the problem of contralateral vasospasm in the surgery for AVM. No disclosure. You know, we know that the AVM can be graded, and this is the pathology and the prevalence. And the vasospasm is something that can happen when you have a rupture of the AVM, or during the surgery you have the bleeding. And this is the data of literature. This is it's a very good article in which the authors review the cerebral hemorrhage due to AVM and what is the incidence of vasospasm with the delayed cellular ischemia. And you see here is about 13–12% of the cases. That was our case. 47-year-old man was admitted to the Western Institute with the right frontoparietal AVM with sign of bleeding, and that was something that is quite important. This is the presentation. Let's see if I can move that. What we can do, we are discussing in the previous webinar, and Vladimir showed a very good experience of them: surgery, embolization, radiosurgery. Radiosurgery was immediately taken out because of the bleeding. So we have the two options, and we decide that due to this institution and after discussion with the radiologist, interventional radiologist, to go to surgery. And you see here that the feeding of the AVM by many arteries, and also with some deep feeders that is coming from thalamus striate arteries. That was the pre-op imaging. Excuse me. That is something that it will come out very important. These feeders coming from the thalamus striate arteries. As you say, the radiosurgery was excluded to the hemorrhagic presentation, and so we went to surgery. The ultrasound intraoperative guidance is quite important. You can see here just mainly for the young colleague. If you don't have intraop MRI that is complicated in this kind of surgery, ultrasound are very, very good. That was the presentation and the opening. This is the ICG that show you what are the feeders. So is helping you to image where are the feeding, and we start surgery. Sorry. Of course, you have more bleeding, but you can manage. I think that for the faculty, all this part is not so important because it's quite a routine for expert of AVM vagal malformation surgery. Nothing in comparison of what Vladimir showed before my presentation. Of course, you can do temporary clipping to see what if you can change, might change the architecture of the AVM, and you will see. Of course, monitoring is quite important, and that was the, let's say, the preparation to taking out the AVM, and that is the ICG that can show the remnant of the feeders, and mainly important, the drainage. So we went again, in very precise way, but problems are always around the corner, and you will see that something happens, there is some bleeding, and the bleeding, I go a little bit faster. The nidus is almost, the AVM is almost completely away. But again, with the ultrasound, you can judge the things, but what happens? A major fetus, a major artery is ruptured, and you have a lot of bleeding, and we are very near to the ventricles. So that was the cause of the problems. Of course, everything is fixed. A ventricular drainage was placed, and that is at the end the ICG that show the malformation is way, and this is the drainage. That is the post-operative. Of course, we have ventricular blood, the blood into ventricles, and some pneumocephalus. The post-op resection was quite good, the DVA post-operative. And also the MRI showed that the brain was okay, and there was no sign of particular sufferance from the point of vasospasm. But the ventricular drainage was maintained. The patient was kept sedated. He had a mild hemiparesis with some agitation. He was transferred to the ward on post-operative day 5, and the rehabilitation began. The problem is that a CT scan was requested by the anesthesiologist, the people that was in the ward, in the 12th post-operative day. It was a Sunday evening. Sunday evening is over, I think, everywhere in the ward. A bad day for complication. The CT scan was done, but no neuroradiologist and no neurosurgeon was called for seeing this until the subsequent morning. And you can see here, this is the right side, the left side, and you see, I think that if I move there, okay, if I move away this, you see here that why the middle cerebral is quite normal, here is very poor. And that was something that should make an alarm. The morning afterward, that was the other control. And you see here that the ischemia was present, and this is the edema of the contralateral hemisphere. So the big problem is that the patient deteriorated, and we were obliged to do a decompression, and that was what we saw in the, let's say, healthy hemisphere, or not surgical hemisphere, in that morning. You see here the ICG that confirm what just the experience was showing, and that is a severe vascular sufferance of the hemisphere. That was it was done immediately, intra-arterial nebulizing injection, and there was some results from the point of view of the imaging. That was pre, and that was post, and you see here that was something was recovered from the imaging point of view, not for the point of view of the patient that has deteriorated and never came back in the same condition that was immediately after the AVM resection. So this is our experience. So we are not just a single unfortunate case. You see here the perioperative mortality was 0. Also in this case, is still alive, but the severe morbidity was present, and the good outcome. The good outcome is 79%. So don't be afraid to do AVM surgery. But that is the ranking scale that is the basis of this analysis of results. And so the consideration and comment. Was the mistake or the the origin of complication was of course the bleeding, but we ignored the angio-CT immediately afterward deterioration of the patient. Should the demodipine injected immediately change the clinical course? We don't know. Anyhow, I think that when you have the suspect of the vasospasm, this kind of procedure should be performed immediately. Some question. What is your experience? Do you perform regularly angio-CT or this DSA 7 or 15 days after the surgery of AVM? Do you have any kind of experience of contralateral vasospasm? Mistake was not a mistake, it was just something that was lack of attention, let's say. And what Vladimir was saying before, we need to have a team working together all day, 24 hours a day, 7 days a week, as advice in comment. So that is the conclusion about vasospasm. And I think that our experience should be shared mainly for young people, young residents. This is our team. Thank you for your attention.
Thank you very much, Professor. This is a fascinating case. I have to say I was not aware of any cases that you have contralateral complications such as that, but in your case, no one can argue because this patient did have an imaging before the ischemic changes happened. We have proof that it was an arterial problem rather than venous on the contralateral side. So very hard anyone could argue. So of another theory otherwise. This is a unique case because otherwise, if you did not have this temporal scans, you could argue maybe there was a venous thrombosis of the status of sinus or so. But in your case, it was
that's the person that was seeing the CT scan that night. Say there is no venous problem, so don't worry. The problem was already present because, as you see, the middle cerebral artery was very thin in the left side.
Yeah, so you cannot argue about the mechanism here much. It's but I must say I haven't come across a contralateral. Of course, spasm is very rare. I may have one proximal to where we resected, but it is very rare, unless other people can share different opinions. Tom, I can see Tom.
Yes, I'm sure lots of the audience and panelists will have an experience of vasospasm, not just in the context of AVM, so distant vasospasm. In our experience, I have 2 cases of distant vasospasm, one in case of pituitary surgery. Again, there was, fairly global vasospasm after sort of extensive pituitary surgery, but was difficult to recognize. But because I was alerted to it, we acted very quickly, and patients recover after a few days completely. But there's also a published case which we had before of a diffuse supratentorial vasospasm after resection of a hypoglossal schwannoma. And again, radiologically proven, treated, and everything else. Again, the patients recover on this occasion, but sometimes these things happen. So I think there are patients who I think, because of their constitution, the way they are made, they are very prone to vasospasm, particularly in certain vessels, and little blood in the subarachnoid space can send them to tremendous vasospasm. So I think that these lessons are very important, because actually in my case, this was the hypoglossal schwannoma case that alerted me on the potential vasospasm in the pituitary case. Otherwise, I might have not even thought about it. So it was a very, very useful case to bring up. It was. Thank you very much.
Thank you, Ramesh. Ramesh, you have.
Yeah, I mean, I agree. It's a difficult case and an unfortunate complication. Don't have a clear explanation, but I suppose the fact that there was intraoperative hemorrhage into the ventricle may have contributed to a diffuse spasm even on the contralateral side. It's an arterial spasm. And whether the early nimodipine would have helped, I doubt it. Often the chemical angioplasty, the benefits are quite transient, especially with such a diffuse and distal spasm. The benefit from such a chemical angioplasty is not long lasting. And personally myself, I know that we as surgeon, we tend to look at our surgical patients more preciously and try to go for everything, including decompensated cranioplasty. But with such a dominant hemisphere infarction in a large extent, I probably don't know whether I would have gone for it, but I think it's reasonable in some cases. And the one other thing which I think, when for AVM, we tend to keep the blood pressure a bit low compared to aneurysm surgery. That may have got some implication. Here, you can't really raise the blood pressure up or do a triple H treatment as you do for aneurysm's case. So that made the management a bit difficult in this case. But I agree. I think overall, it's sort of unpredictable complication, and I don't know whether anything else could have done for it. One other thing which I have to mention is a similar AVM I did in a young nurse who came with a bleed. There was a perforator coming from medially, which could not be accessed even surgically. I didn't want to traverse through the white matter, get into that feeder, so which I left. And subsequently, she was sent for gamma knife for that. So they are difficult one to tackle surgically. Thank you for showing this case.
Thank you.
Thank you. Now I hand over to Nikolai.